corrections too. So here we'll be talking about if a child has abdominal wall defects, like it's so large, there's a procedure they do for it, silo. So they say silo for large abdominal wall defects. So I'll quickly try to look at what this silo is, okay, and how they actually do the silo procedures. So first of all, abdominal wall defect is more of like the stomach, there's a defect, so your intestines are outside, right? So if the abdominal wall defect is so large, there's a way they do a silo. A silo is more of like a bag. They bring a bag, they put the intestines in it. Of course, this to protect against a lot of things, okay? So this silo, basically it covers the intestine, so this will protect it from maybe infections and all of that, drying up and the rest of them. So the silo, just so you know, is a temporary protective device. It's used in the management of large congenital abdominal wall defects, commonly gastroschisis, okay? Then sometimes if omphalocele is so giant. So it allows for what? Gradual reduction of the herniated abdominal content, okay, back into the abdominal cavity when primary closure is not possible, okay, because of the size. Like the defect is so large, so you have to just protect it, okay, before maybe later on it can just gradually go back in. So indications: when will you actually want to use a silo? You want to use a silo when there's large gastroschisis, giant omphalocele, okay, then infants with hemodynamic instabilities. Who is this fool over here? If you don't understand what the life is about, you can get out, okay? So what's the principles of silos? It's a sterile, it's a transparent bag, okay? So the suture is to the abdominal wall, okay, around the defects, okay? So the exposed bowel is what will now be placed into the silo. Do you understand? So what are the protections? The silo will protect the bowel from trauma, infections, fluid loss, okay, allowing visualization of the bowel viability. So gradual reduction. So over this, the silo is gently compressed so that it will be pushing the bowel back in, okay? So each day more bowel is accommodated into the abdominal cavity, like they push it back more, okay? Now definitive closure. So once the viscera have gone back to a large extent, the silo will now be removed, okay? Then abdominal wall defect will now be closed. Do you understand? So it's something that they bring in once they know that the abdominal wall defect is so large and it's over time they have to correct it. So advantages is it actually avoids sudden increase in transabdominal pressure. If you want to just push the abdominal wall back in and the baby has not developed to some considerable, size. So it also allows for bowel recovery for edema and inflammation. It's safer for neonates. It reduces the risk of respiratory compromise.